Good afternoon, everyone. Thank you. My name is Tracy Perrizo, and I am the program officer for the New York City program at the Helmsley Charitable Trust, where we focus on stabilizing health for high-needs patients. And over the last 4 years, we've directed lots of our grant making to homeless healthcare, innovations in homeless healthcare. And you are at the Aging and Thriving in Place and Supportive Housing session, in case you wanted to check your schedule. That's what we're doing here. And one thing I wanted to start with is to ask if everyone in the back can hear. Everyone in the back? Great. Okay, and we're all going to speak into our mics on the panel so that people can hear you. Great. Okay. I get that right, Cynthia? Great. Okay. So, today I think we're lucky in that we can start with a statement that's optimistic, and that's that people are staying in supportive housing longer than before. And with that, we're also hearing people want to continue to age in place and in an independent way, right? So living in independent housing. So that's a good statement. I think it says a lot about supportive housing and the success of the model. However, it presents a challenge that we aim to talk about today here on this panel. And that's that supportive housing wasn't designed to age in place, right? Not in form or in function originally. In form, we know that nearly 70% of affordable housing stock in New York City requires at least a set of stairs. I doesn't say how many of those stairs, but a set of stairs to access. We also know in function, most supportive housing programming adapts well to individual needs for single adults, for sure, to live independently, but there's a different set of specializations required for aging in place. And so we know also that homeless adults, people experiencing homelessness, are often showing signs of aging up to 20 years earlier than the general population. And so that presents a service need for some providers. Also, the age-appropriate supportive housing supply is falling further and further below the demand, which is increasingly growing, right? So we're hearing that the Corporation for Supportive Housing, anyway, is estimating that in the next 30 years, the population of elderly homeless adults will double. So these factors, I think, make this conversation quite urgent to have soon, because we know that living independently brings lots of health benefits and also benefits to well-being. So luckily, today, we can hear from 3 providers who've tried this, who've been cracking this nut, The Bridge, CUCS, and Breaking Ground. And each of them have developed a creative response to this challenge, or are developing a creative response. And so what I think we'll do today is listen to each of the panelists talk about their model. And they're in sort of decreasing state, they'll talk in decreasing stages of development. So we've got one person whose model is quite developed, next who's a little bit less developed or more recently developed, and then one that's in development now. So you can hear a whole range. So what we'll start with is introductions, and then we'll save some good time at the end for your questions. Okay. We'll start with the person in the middle, and that's Rebecca Heller. She is a licensed clinical social worker, and is currently the Assistant Vice President of Aging and Clinical Services at The Bridge, where she oversees the first and only mobile treatment care team focused on geriatric mental health within supportive housing. Rebecca has been with The Bridge for nearly 5 years. To her left is John Betts. John is the Assistant Vice President of Program Development and Innovation at Breaking Ground, where he oversees the aging services team as part of his portfolio. He's trained as a social worker with a focus on adults experiencing homelessness. Prior to his work at Breaking Ground, he was a program director at Bronx Works, where he oversaw mental health shelters, drop-in centers, and safe havens. And over on the right, Van Yu is a psychiatrist and chief medical officer at the Center for Urban Community Services, otherwise known as CUCS, and its healthcare affiliate, Janian Medical Care. Dr. Yu spent 4 years at the Bellevue Hospital Center's Comprehensive Psychiatric Emergency Program, I think we call it CPEP, and before coming to Janian in 1999. He has served as medical director of the Manhattan Outreach Consortium from 2007 to 2013, and it must be in his spare time, is a clinical assistant professor at NYU School of Medicine. Welcome and thank you to all of you for being here today. And like I said, I'd like to start by hearing from you, Rebecca, where you, as you developed a program that's been running now a few years, I believe, and it has a really fantastic name, Magic. Can you tell us about that and how you developed Magic specifically?
Sure. I'm going to do that. Can all the bridge people in the back hear me? Yeah? Okay. Closer to the mask. Okay, great. Yes, so the Bridges Aging Services Program was created around 6 years ago because we realized, of course, like all of you, that a lot of our clients were older adults. And as far as we know, we're the only multidisciplinary mobile treatment team. So just to break that out, right, multidisciplinary, we have an assistant program director who's a benefits and entitlement specialist. We have a registered nurse and a licensed practical nurse, a certified peer specialist, a part-time occupational therapist, that's our cool wild card, and then 3 master's level social work students that we take every year. And the mobile treatment part, of course, is that we are in the field, we're in our clients' homes, and the Bridge has different levels of housing, community residences, apartment treatment, scattered site, and we serve clients in all of those types of housing. But if we just served all our older adults at the Bridge, it would be about half of our 1,400 units. So that was way too many people, even for my wonderful staff. So we developed the MAGIC model, because you need an acronym, and it stands for, the M is for medical needs, and again, medical needs that are not being met. So not just an older adult that has diabetes, an older adult that has diabetes that's not being currently supported or managed appropriately. The A is for activities of daily living. So of course, that could be going to the bathroom, preparing food, transportation, managing finances, things like that. The G is for gait disturbance, because I couldn't think of an acronym with an F for falls. So we did gait. And again, we really, the ballpark is 2 or more falls in the last 12 months. The I is for isolation. I did have one client who loved COVID because everyone left him alone. So again, not people who are want to be alone, right? But people who wish that they were more connected. And the C is for possible cognitive impairment. And for each of those letters, we have an evidence-based assessment that we did not create, that exists. And we meet a threshold for each one to kind of help with our admission and discharge criteria. I could say more, but I think that was your question.
Great, yes, thank you. And, I wonder if you could just give us a little more color on how people are deemed eligible and admitted to the program?
Wonderful, yes. So luckily, because we've been around at the Bridge for a while now, people reach out to us and say, I have a client. I also sit on our IRC, our Incident Review Committee, so if there is an older adult that sort of meets that criteria, I'll look into it. We also have something called the OANA, another acronym, that stands for the Older Adult Needs Assessment. And so this was really to help us with our data. So the OANA is a agency compiled, but again, is evidence-based assessments that exist. And we pull them all together, and we ask staff to complete one for every client 50 and older across the agency. So this year, that was 850 residents. And I guess I didn't say, but we have 1,400 units across the Bronx, Brooklyn, and Manhattan. So really about half of our clients, right, are 50 and older. And so we then look through the older adult needs assessment, and we'll see if there are people who could benefit, who we're concerned about. What's really cool about the OANA is it's on our electronic health record. So I get every last one because I have the list, right, of every client, and I know their age. So this is our 4th year where we've had 100% completion. So we now have a really interesting data set. So we're working with a professor from Dartmouth, Professor Karen Fortuna, who studies older adults with SMI. And we're hoping to publish that and kind of use it both for our own data, but to add to the literature, because there's just so little about our clients.
Great. If there's anything else you think, I think how long you usually serve them, you may as well just dive into it.
Yes. Sorry, I don't want to make you Tracy.
Sorry, I should have specified how you developed it.
How I should.
I think really round it out as you'd like us to hear about the most important components.
Perfect. Okay, thank you. I just want to sort of touch on our Advanced Directive initiative. I loved the session I just went to about death and dying, and of course that's not this session, but it's not unrelated when we're talking about older adults. And so at the Bridge, we also started an Advanced Directive initiative where we encourage all clients 18 and older, which is all of our clients, not just our older adults, to complete an Advanced Directive. And as a sidebar, all of us should have an Advanced Directive. I won't make people raise their hands, but I have an Advanced Directive, right, because it's both a living will and a healthcare proxy. And so at the Bridge, we sort of simplified the language for our clients, and we made healthcare proxies optional, because of course not everyone has a person who they can designate as a healthcare proxy. But I think that kind of rounded out sort of this culture change that I think is also an important part of the model. So, because we have this specialized team that is talking about aging in place rather than a higher level of care, I think staff know at this point the way to make me very upset is to just call me and say this client needs a higher level of care, because I'll say, how do you know that? Do they have home care? Why can't they age in place? And so I think it's really all of these different initiatives, right? They're filling out the OANA, they're talking about advanced directives, they see that there's this team helping clients age in place, that it sort of changed the dialogue. And I'll just add that, of course, there are a lot of ways up the mountain. We've had a specialized team internally that sort of can both act as a consultant and also provide direct care. And I think, there are a couple strengths to having a kind of a strategic specialized team, one of which is the partnerships that we can create. So, for example, home care is very complicated, unnecessarily so, but it's very complicated. And so our team does it all the time, and we have partnerships with home care agencies. So if there is a client who might be a little more difficult, we have a relationship with that home care agency, and they're less likely to kind of get discharged from home care, for example. Kind of another benefit of our specialized team is our multidisciplinary approach, right? So I mentioned our OT wildcard, and she looks at things very differently than I do as a clinical social worker. I had never heard the term energy conservation. But she, encourages clients to sit down when they can, rather than stand up and make their smoothie, they could sit down. She said, this person should keep a cane by their bed, because when they wake up in the middle of the night to go to the bathroom, they trip. Things that she just is sort of attuned to things differently, sort of in the way that our nurses can sort of interpret information differently and can explain to clients and staff what words mean, how medications work, and so I think our model has been very successful because we're really fully integrated within the Bridge, and we have a lot of support from senior management, and so we can kind of touch clients and staff in different ways to really help our clients age.
Great, thank you. And could you say one more thing, Rebecca, about how long you generally work with people?
Or that was your only question, and I didn't answer.
I'll encourage those. It's okay. It's all interesting. I just want to.
You're very kind. I didn't answer the question. I actually tried to look this up, and what's hard is that we almost have different tracks, right? We have let's say there's a client using the home care example, right? It's very clear. They come in, they need maybe a pool trust to get Medicaid, to get home care, let's say. We set them up, and then we step back. That's really what they needed, and they're doing great. There are other people that we're never going to discharge them from aging services. They have certain frailties or we have certain concerns about them, and they just really always will need our sort of second eye. And so if I pull our length of stay, it's not really accurate because there is such a range of the way the program is used. We have started using person-centered service plans that we created, where we really focus on sort of what is their magic letter, what is the goal in the client's own words within that magic area that they're working on, and I think that's going to be a better metric for us to kind of see, are they meeting the goal that they have around their aging, rather than sort of the official length of stay. I can say in terms of numbers, we hover around between 130 and 150 clients that we can actively serve, and our minimum is seeing them once a month. And again, it depends on what's going on. We really focus on people who are just got discharged from the hospital, let's say, or rehab, or if there's a fall, of course, they might get visited more or less depending on what's going on.
Great, thank you so much. And lore has it that Breaking Ground actually heard Rebecca present. I believe it was Rebecca presenting.
It was me, yes.
On magic, maybe at this conference or okay.
It was this conference.
Okay, a few years ago. Getting it right. And then went back to develop their version of the program, and it looks a little different. John, could you tell us a little bit about that and how it differs, particularly from the Bridge?
Yeah, sure. So Aging Services at Breaking Ground was indeed born at the Shinny Conference. That was prior to my time that conference occurred, but the Aging Services team was still fairly new when I started. So it started in 2019 thanks to funding from the Samuels Foundation. And it really has three prongs of services. So the first prong is what we call an auxiliary case management service, which is focused specifically on short to medium term interventions, specifically focused on older adults. And we see Aging Services as supplementing rather than replacing the supportive services staff that is on site at the supportive housing setting. What I will say, and I'll talk more about this in a moment, is that we've also found, because as a supportive housing provider, we strive to provide services for everyone in the building, regardless of whether or not they're in a designated supportive unit. Many of the folks, particularly at our senior buildings, Breaking Ground has a couple of senior buildings, and particularly at our senior buildings, what we're finding is that the low income or community tenants are also moving in and developing needs over time. Similar to what you mentioned, Rebecca, folks are staying in our housing longer, about a year and a half longer on average for our older tenants than our tenants who are on the younger side of things. And so Aging Services has also become really vital to help the folks in the community units continue to remain in their units so that they can age in place as well. And particularly around things like connecting people to home care, connecting people to Medicare enrollment. So that's the first prong, is the auxiliary case management service. The second prong is groups and socialization and reducing isolation for those folks who want to have their isolation reduced. We found through some of the initial assessments that we did that there was a plurality of folks who really wanted to be involved in the life of the building but didn't necessarily know how to do that. And so Wale Adegbenle, who is our Director of Aging Services, who has really shepherded this from the beginning, has done a lot of work in building relationships with community organizations in order to have them come in and run groups. So we've been working for several cycles with the Theater of the Oppressed NYC, which is an organization that uses theater and theater games to amplify un- and underheard voices, particularly around sort of community engagement and relationships to power and sort of claiming agency. And then we also just finished and are hopefully about to start another cycle of a virtual cooking group with the Sylvia Center. So We had some funding that we were able to purchase ingredients boxes that we had shipped to people's apartments every week, and then they got on Zoom, and there was a chef educator who taught them how to make delicious meals, and we've gotten really good response to that. We've been having diabetes self-management groups, as well as fall prevention groups. And one of the things that I'm really proud about is that Wale converted all of these older adults to Zoom, many of them who had never used Zoom previously. Our agency just recently made the shift to Teams, and Wale came to me and was like, no, we have to stay on Zoom. So that has been super great and has opened up another avenue for people engaging, and also a sort of supplemental benefit to that is their ability to then use that technology to engage in telehealth when necessary. And then the third prong of it is really training the next, not only our current staff, but the next generation of folks who are going to work with this continuously aging population. So we've either put on, Wale has either put on or brought in speakers for over 60 trainings since we started this in 2019. So Wale and his team maintain a very full training calendar. Speaking to the sort of small nature of these teams, Wale is currently the only full-time staff member. The rest are a sort of rotating cast of social work interns. We did just get some funding to begin to sort of build out this team. And I think we may talk about this later, this is an area which is grossly underfunded in terms of being able to provide the level and intensity of services that many of these folks need. So we have also done some work around advanced directives and care planning, particularly healthcare proxies. We knew that units sitting offline after someone passed away without will was not only preventing someone else from moving into that unit, but it was also then costing money because that unit was sitting vacant. And what we found is that simply being connected to aging services, we have some preliminary data suggesting that simply being connected to aging services, regardless of whether or not the person had completed a will or a healthcare proxy or anything, simply being connected reduces the unit turnover time from the time that the person either moves on to a nursing home because they can't sustain with the home health care anymore or passes away. We don't quite understand why that is 100%, but it's on the order of like 90 days. So it's not insignificant. And we think it has to do with the sort of engagement. We had a gentleman who had a stroke and really needed to move into a nursing home. He was no longer able to transfer. He needed 24-hour care that we just weren't able to provide. And he was someone who had sort of like dug his heels in and was really very much like, no, I'm going out of this apartment feet first. Like, you are not going to get me into a nursing home. And through conversations with our property management team and the aging services team, they were able to help transition him into a nursing home and get him to agree to sign a surrender agreement so that he would surrender the apartment in a process that otherwise would have taken 6 months to a year. And so even if it's not as a result of sort of someone passing away or that advanced directive per se, simply the engagement and the relationship, as we know it does in many ways in supportive housing, goes a long way to helping people be able to make their own decisions.
Great, thank you so much, John. And I'm going to move to Van, who's developing this program at CUCS. Am I right in saying that?
Yep,
Yeah.
You're right. Thanks, Tracy.
Yeah.
So I'm going to start by describing CCS and Janian a little, just for a couple of minutes, just to orient you to who we are. And then a little bit of a history of our initiative, and then I'm going to say something specifically about how I think we're different. We've taken a different strategy, and why I think we've taken that different strategy. Although I am a little jealous of the team-based approach that especially Jessica's. We definitely internally debated that, but decided to go the way we did, and I'll explain why. So CCS is a big social service agency that operates a lot of different services for people with lived experience of homelessness. So, for example, we're the lead agency for the Manhattan Outreach Consortium. We operate a couple of shelters, a safe haven. We're about to add a second safe haven. And we have a bunch of supportive housing. It's probably the biggest thing in our portfolio. We have about 2,800 units of supportive housing right now. We have about another 1,000 units in the pipeline that will be up in the next 2 or 3 years. Janian Medical Care is the healthcare affiliate. It's the part of the agency that employs all the licensed healthcare providers, so nurses, nurse practitioners, and physicians, both psychiatry and primary care. And since this is Shinny, we're going to talk about the supportive housing side. In the supportive housing side, remember I told you there's 2,800 units, give or take, and I'm just trying to do the math in my head. It's about 15% of those people see Janian either primary care or psychiatry or both. So it's a subset of that. We really try to focus on people who really can't access care in the traditional system, right? And of that group of people that see us, I think it's something like somewhere between 50% or 60% of those people are age 60 or over, and that number is just going to keep getting bigger over the years. For example, I'm the psychiatrist at one of our supportive housing sites. I've been there for like 15 years now, and a bunch of, I'd say 15 of my guys, we're all aging together, and we're actually joking about it a lot recently. We're all like getting the same old man diseases, which is nice, but also like a little alarming, because what are we going to do about it? So that's in a nutshell. This got stuck in my head a few years ago, watching my own patients and watching myself, all doing this together, right? So we're all aging in place. Anyway, so Janian got its start in 1986 as a thing called the Project for Psychiatric Outreach to the Homeless. It was started by this psychiatrist named Catherine Falk, who grabbed a bunch of her friends and started volunteering at homeless shelters. And then sort of in the early to mid-90s, it started hiring salaried psychiatrists. In 2012, 2011 or 2012, we became Janian Medical Care for all kinds of legal reasons, which I won't bore you with. But that actually gave us the opportunity to start our primary care program then. And then we added to that street medicine in 2016. Our psychiatry program now serves people at about 70 different programs, both CCS programs and programs of other agencies like Breaking Ground and Goddard, Urban Pathways, West Side Federation for Senior Supportive Housing, etc. Primary care, I believe, is now at 15 or 16 places, and then we have 2 Manhattan Street Medicine teams and 2 Brooklyn Queens Street Medicine teams. So that's sort of the scope of what we do. As I alluded to earlier, a few years ago, I started really getting concerned about both the population in our own supportive housing that was aging, but also the population of people who are homeless in New York City as a whole, for reasons that I'm not an expert at, but are definitely, I've seen sort of multiple data about this. It's aging. Both people entering homelessness are sort of on average getting older, and then of course the people who are homeless are aging as they're homeless, right? And I think the 3 agencies recognize this in different ways at different times, so this is why we're all trying to do something about it. So a couple of years ago, we got some funding from the Fan Fox Foundation to get a geriatric care initiative off the ground at our place. And the first thing we did is we hired, we promoted Justine Warren, who's over there, who's as our director of geriatric and palliative care. She's a primary care provider. She actually should be sitting here, but for reasons I won't get into, I'm sitting here instead doing it. It's not her fault. So let me talk a little bit about the strategy we've chosen that's different, right? So we definitely debated about doing like a team-based strategy, like a team layered on top of everything else we were doing. But the administrator in my head's like, how am I going to pay for that when the Fan Fox money runs out, right? What we ended up doing instead, and I know there are people in this room who might have a different version of how this conversation went, but my memory of it was that, in my head anyway, I decided, no, what we're going to do instead is we're going to take the structure we already have and just make it better at this, right? So instead of layering a team on top of what we were doing, take the psychiatrist and make them a geriatric psychiatrist. Take the primary care provider and make them more of a geriatric primary care provider, right? And so right away the problem is, well, our psychiatrists and primary care providers are really good at serving people with lived experience of homelessness. We're like these community provider expert type people. But almost none of us have specific training in geriatric care or palliative care. A couple of us do, but not me personally, but a couple of them do, right? But not as a group, right? And on the other hand, which we haven't really alluded to, but it's sort of implicit in some of the stuff these guys were saying, is that the system of care, of geriatric care, and then particularly palliative care and even hospice care in the city, not just New York City, but in general, that's what they're good at, but they're not really well positioned to provide that kind of care to people who are homeless. So, for example, one of the things we were running into, which is off the topic for this talk, but I'll just throw out there, is people requiring palliative care or hospice care in like safe havens and shelters, and how the hospice care providers, they're just not positioned to do that well. It's not even that they don't want to, it's that they sort of can't figure out how to do it. They're not set up to do it. And then we're not hospice care providers. We're no good at it either because we don't know how to do it. And we're also not well positioned to do the kind of 24/7 kind of operation that some hospice requires, some hospice care requires, and some palliative care requires. Anyway, so that's just a little bit of a tangent on one of the needs that got us going about this. Anyway, so the strategy was, let's make our current structure, our current provider team just better at doing this instead of layering something on top of it, right? And then just thinking about the money thing, because I'm already paying for that, right? So it's basically I'm asking people to do more, but it all costs the same at the end of the day, right? So my idea was that, with some upfront help from Fan Fox, we get this thing rolling, and then some of the initial upfront costs will go away eventually, right? And there'll be some maintenance costs, but I'll figure that out later, right? That can I felt like I could kick down the road. By the way, I will add that we're 2 years in now, and the Stavros Niarchos he's sort of coming to the rescue. Fan Fox is going to run out. Stavros Niarchos is going to help us. He's given us some grant money to replicate what we're doing on the primary care. So we're starting with primary care on the psychiatry side. So get that going. It's going to be very similar. Okay. So I started with, the first thing we did is we promoted Justine. And then I think Fan Fox gave us this idea. They introduced us to the, I'm not good with it. It's Haney's. I think it's Healthcare Associates of New York. They're running this age-friendly health systems seminar series. Mm-hmm. John's shaking her head. It's awesome, by the way. I highly, highly recommend it. So Justine did it last round. I'm doing it this round. And it's a sort of this coalition of healthcare providers in the state. It's mostly hospitals. There might be a couple nursing homes in there. I think we're the only homeless healthcare provider in the group right now. And the mission of the group is to try to create this sort of like common way of addressing geriatric care, which is this 4 M's approach, right? So we've been very deeply influenced by them, and you'll see how we've set our things up based on this approach. So the 4 M's, I hope I get this right. Mentation, which is cognition, right? Medications, which is the thing we're really going to struggle with because we haven't figured it out yet. Mobility, which is like ADLs and functional, and what matters, which is this advanced care planning. You're shaking your head. Thank you. Yes, I got it. Right. Thank you. Right. Okay. So the first step, this is what we've done so far, right, is we've rigged our electronic medical record. Like, this is another issue, right? How are you going to track all this stuff? We've rigged our electronic medical record to assess all this stuff, right? So we've put tools that are, we hope, easy for the providers to use to start assessing these things, which they either weren't assessing before, or each person was assessing in their own idiosyncratic way, or this very informal way, to get everyone to do it in the same way. So that, for one thing, we know how many older people we have, but we're sort of blind to, like, well, what's going on with them, right? Except anecdotally. So this is one way to sort of get a handle on, well, what's even the problem we've got, like, in more than a general way, right? So just to fast forward a little bit, so we're collecting all this information, and then we're going to see what we got. Then we're going to decide, okay, what do we need to do about it, right? So we're not, these guys are already, here's what we're doing about some of this stuff. We're still trying to figure out what we've got, like what the problem is. So this is why I'm going third, because we're a little far behind these guys, right? Okay, so let's go back to the 4 M's. So mentation, we decided to use something called the mini cog. It's a two-question assessment. It's remember 3 things in 5 minutes. Remember that one, right? And clock drawing. That's it. That's the mini cog, right? And like a lot of these things, I'll just say this now. It's a screener, right? It's not meant to tell you that much, except it's meant to tell you that there's something up, right? So if somebody fails the mini cog, that's when you then pull out your MoCA or your mini mental state exam or something like that, or send someone for a head CT or that sort of thing. Okay. So the mobility one, we're actually using 3 things. Let's see if I get these 3 right. There's a CATS ADL scale, there's a Lawton ADL scale, and something called a timed up and go. I won't tell you what they are. You can ask me that later. Okay, so we're using those 3. And again, those 3 are super easy, super fast. Even me, the psychiatrist who's never been taught how to do them, uses them, and I think they work really well. Okay, and then the medication one, let's put that one aside. We're not doing that one yet. And then we're doing a pain scale. We're using the PEG. The PEG, I don't know what it stands for. The P is for pain, but I don't know what the EEG is. Anyway, it's a 2-question Likert scale. It's a 10-point Likert scale about pain. And then and then what matters? What's that? So a what matters evaluation assessment is kind of an advanced care plan, but it's like one question, right? It's what matters. It's basically what matters to you. What is your priority right now? What do you care about right now, right? And the reason we're doing that is because for twofold, instead of other things we could be doing. It's not clear to us how effective advanced, like these sort of more traditional kinds of advanced care planning tools are, like MOLST. I know our people use MOLST a lot. It's how effective they are with our population, right? Mm-hmm. For a variety of reasons. Like, for example, here's one reason. Person lands in the hospital with like a filled out MOLST, and then the hospital people just ignore it, right? That happens all the time. I don't know why that happens, but it does, right? So that's sort of one of the challenges we've run into with those kinds of things. And then what matters also, it's like serving 2 functions, I think. It's both an advanced care, well, what it ends up being depends on what someone answers to the question. It's purposely meant to be the super open-ended question, right? And some people end up talking about medically related things, but some people end up talking about other things. So I'm just giving you one example. So one of my own patients, who I've known for like 10 years, I thought I knew everything about her. And I asked her this question. Okay, so, what matters to you right now? What's important to you right now? She's like, well, I haven't seen my sister in 2 years. I'm like, I didn't even know you had a sister, right? What's the story? So I learned that her sister lives in the Bronx. They used to ride the train to see each other, but since the pandemic, they've been both afraid to get on the train. So they haven't seen each other in 2 years, right? So to me, this is a great story, a great example of the power of this instrument, or it's not even an instrument, this tool, I don't even know what to call it, because I learned this thing I don't know about my patient that is so easy to know, And I have an idea of what I can do about it to try to help her with it, right? So that's just one example, right? And that's not like an advanced care plan per se, but it's something that's really important to her right now. Would really, it's the thing she cares about. She doesn't like care about the risperidone I'm giving her, and she shouldn't, because I don't know that it's helping her, right? But that she cares about, right? So, okay, I'll say one more thing, then I'll stop. So we're collecting data. We're trying to get a picture of what we have, and then we'll start, like, what are we going to do about all these pain? We're going to get these bad pain scores, I know, right? But, so one of the things we're going to do is we're going to make ourselves better pain doctors, right? Better pain providers, right? So we have to figure out how to do that, right? So the medication thing, that's one of the fourth M that we haven't talked about, and that also we're not sure what to do about. And that's like mostly, it's deprescribing, right? Like as people age, they get more sensitive to the side effects of the medications they've been on, even the ones that have been fine before, right? So for example, on the psychiatry side, lots of anticholinergic stuff. Actually, a patient of mine just ended up in the ICU a few months ago because he was taking more Benadryl than I was prescribing, but I probably shouldn't have been prescribing them in the first place given his age, right? So that's just like an example of a medicine you would want to deprescribe. And I asked this question at the Age-Friendly Health session on this. It's like, how do you track this? When you think about it for 3 seconds, you'll get how this is so problematic. Like, what medicines? Like, there's a whole Beers criteria list, right? For those of you who know that, there's like hundreds of medicines on this list. How do you track who's even on those to begin with? And how are you going to track that any of this stuff's been deprescribed, right? So I don't know what to do about that one, but that's definitely so that's like a future item. That's something I'm going to make the psychiatry person take care of that. The Stavros funded psychiatry person is going to tackle that one. So that's where we are. We're collecting this data. We've got a couple things we haven't even touched on yet. We're going to start thinking about how to make ourselves better at some of the interventional stuff, and go from there, and figure out a way to pay for it all. So that's my story.
Great. Thank you so much, man. And I always appreciate your honesty about where you're at with things, too. But you figured out and haven't. I'm struck by a couple of themes that I was hearing amongst you. And if I may, I want to just ask about, I was hearing different approaches from upskilling your team, which is, I think, what you were talking about, Van. You're pushing it in and hoping it stays in, I assume. That's the nature of my question. Versus layering a team, right? And I just wonder, aside from paying for it forever, that's another question I was hearing everybody talk about, right? Which is, which I'll try to carefully stay away from.
Yeah.
Until another time. But I wonder about how COVID, for example, has impacted this thinking, because one of the things we hear so much about is how much turnover on your own teams that you have. And so if you have opted for the upskill version, how are you thinking, how has that been impacted over the last couple of years, and has that changed or evolved your thinking about it? And I know you have a training institute. We don't all have a training, not everyone has a training institute attached, and I'm not even sure that the CUCS Training Institute is doing the upskilling. It doesn't sound like entirely that's true. It's from an outside.
That's a good point, yeah.
But I wonder, and similarly with the layering on a teams approach, has your staff turnover affected the way you think about this? Have you had to adapt to that recently? Maybe Rebecca, do you want to start with that?
Sure. Yeah. So clearly, we went the route of having kind of a specialized team. I think the Bridge felt that our frontline staff are already so maxed out beyond belief. Even before COVID, that was true, and that it just wasn't. It wasn't reasonable to expect them to also be geriatric specialists on top of it. And so. Obviously, funding is the biggest problem with having a specialized team, right? Because there are extra people to pay for. But in terms of sort of the consultation model, I think has worked really well. The kind of roll on, roll off, that we focus on the priority clients, right? Those partnerships, that knowledge base. These systems are complicated, especially with our clients. It's so hard to know: is this mania? Is this dementia? Is this and to help navigate those systems with clients, and really to be a respite for staff too. Staff will call me. Recently there was a client who went on hospice, thinking about hospice, right? And we helped navigate that. We're sort of, because we're in the geriatric behavioral health space, which is a small little space where we mostly all know each other, I could pick up the phone and have someone who's really an expert in hospice talk directly to the staff and alleviate and support what was going on for them. So in terms of getting the best care to the clients and really supporting staff, I feel like that model has worked, though of course there's pros and cons to both, and I really also see the benefits of training staff and things like that. But I think because of that turnover, I've been lucky that my staff hasn't left, and they're still there, and so there hasn't been staff turnover within our specialized team. So we really keep all that knowledge and those partnerships close. So it works well for us.
Great, thank you. John, have you grappled with this?
Yeah. Well, first of all, our team started, I believe Wally started in July of 2019, so he was just getting his feet under him when COVID started, and then I started in early 2020, so we sort of haven't known anything other than COVID times. We are also dealing with the turnover issue in a sort of unique way, because much of the support comes from social work interns who are rotating through every 6-9 months. And so one of the ways that we adapted to that was we just recently finished the sort of standard operating procedures manual for our aging services team, so that not only the programs that we work with across the agency, but also new staff and new interns coming in have a place to start, so Wally doesn't have to re-explain the same things over and over again. And it also, one of the sort of freedoms about the sort of paradox of the funding issue is that it also gives you a lot of freedom to sort of measure whatever you want, collect whatever data you want, and not really have to say, okay, we have to achieve this outcome because this is what the funder says, right? Obviously, we have the responsibility to whoever the grant funder may be, but it really also allowed us time and space to think about, we're calling it sort of aging services 2.0, now that we've moved out of this like initial grant period where we had set sort of prospective and anticipated outcomes that we thought was what we were working toward, but in the course of sort of delivering the services realized maybe we missed the mark on some of the things. So it really allowed us to take a good assessment of sort of where we were and where we wanted to go. And I also think that to the points that others have made, like relieving the pressure on the frontline staff, I think particularly for the community units, that without, we know assessment for a home health care agency is complicated, ever-changing, takes a lot of time, right? So in some ways, we also see it as an additional support for our staff, that this aging services team that's really good at this, knows a lot about this, and has relationships with the home health care agencies, rather than a case manager having to figure it out for themselves and start from scratch, can say, hey, this person needs home health care. I'm going to hand them off to you for that sort of concrete need, and once they're set up, I'll sort of take it back. And that's better serving the client. It's a better use of staff time and allows them to be able to serve other clients without having to take time out of that to sort of figure it out from scratch. So those are my thoughts on that.
Great. Dan, do you have any comments?
Yeah, I'll start by talking about something that's not exactly your question, but I'll get to your question, which is that so Janian isn't the social service teams at the supportive housing programs. We're the visiting psychiatrists or primary care providers, even though we're all one agency. So we have not to date asked the social service teams to do anything about this, right? We're just asking our own people, our own providers to do stuff, recognizing that what you guys alluded to is that everyone's stressed out by everything else they have to do, and they don't have the bandwidth to add anything more. And it's also like, the CUCS has like 500 employees, and I can't think of all those people. So it's also too much for us, right? So there's all these roles that these guys are asking their social service people to do that we're either not doing, or we're trying to do it ourselves. So we'll see how sustainable that is, right? But now to your question, yeah, this is going to be a real challenge. We haven't had a lot of as much turnover as you might expect during COVID, although we've had some. Although we're having a really big recruiting problem, right? So it's not that we're losing lots of people; it's that we're having trouble bringing people in as we're growing. But we recognize it's going to be this ongoing training issue, right? And we have a lot of things set up to keep people trained, right? So there's dedicated training time for all the providers every week. There's a supervisory structure that makes sure there's it's not face-to-face in person these days, it's Zoom, but there's a lot of supervisory. So that supervisory level of people hopefully will be really, really expert, and so can really support the people on the ground. And those supervisory level people themselves are also patient caring people also at the same time. And then also, as I mentioned before, we've tried to put things inside our medical record that make it, because of the structure of it, make it not exactly automatic but easy, right? Like, so for instance, from the way we put it inside of our medical record, and then the tools we picked. For example, of all the cognitive assessments we could have picked, we picked the shortest one, the 2-question one, right? So, and you don't need a lot of training to do it correctly, right? It's right. The first time I did it, I just looked at him like, oh, that makes sense. I know how to do this, right? So I didn't need to be trained to use it per se, right? So we're looking for things like that you don't require a lot of ongoing or even upfront training. So that's my answer.
Great.
To that.
Okay,
Yeah.
that makes a lot of sense. I'm also was hearing all of you talking about funding and how to sustain these things, and so I will ask the question: Are there groups of people? Are the three of you maybe part of those groups that are talking about this together? At this stage, are you talking about staking out some of the outcomes to watch? Who payers for sustainability, for example, might be other than, funders who can come and go and those kinds of things, right? It's usually hopefully there's some kind of a path towards sustainability. Do you do that kind of work yet, or is this so emerging that not quite yet?
I would love to join a group of people talking about this. And I guess we're starting it, right? We're here. But I think the problems that we've run into is that, of course, the obvious problems with grant funds that run out, and that, they have their own ideas sometimes of how their money should be used. But it's also the sustainability piece. And the problem is, how do I show that the program is changing outcomes, right? How do I show that I'm saving the system money when the system is so siloed that even if I'm saving money over here, the system over here doesn't really care, even though I know that they're connected, right? Like thinking about nursing homes versus hospitalizations, or thinking about even supportive housing, as we all know, is so much more affordable than the alternative, but they're not connected in those ways. Let's say we keep a client in the home another month, right? And then they go to a nursing home. How do we show that savings, And so even though we're really working hard to get data, and the Bridge is affiliated with Weston United, and Aging Services right now is not in Weston United. So you would think, oh, that's a perfect, kind of sample group. And it's taken, I think, weeks of meetings with our data people because it's so complicated, right? How do you show, that this would have happened, and pulling out all the different metrics, and obviously I'm a clinician, not necessarily a data analytics person. I'm becoming one. So I think the sustainability is like the $1 million question, but also the onus is on us, the provider, to prove that we're sustainable when we don't have, fancy data people that are crunching these very complex numbers, right, with all these multiple facets of healthcare and quality and costs and things like that. So I wish it were clearer, and maybe other people have a better way of figuring it out, but it's been very messy, even though it seems like it should be simple to show. And of course, we know that we're improving outcomes, but it's anecdotal.
Okay. That's always a hard question. I forgot to mention to the audience, if you stay to the end, there may be drink tickets or something, if we drink. I'm just kidding. I know the reception is after this, but I appreciate it, your good attention all the way through. Uh-oh, no. That's the problem with that joke. I do want to. I think there's a lot to talk about with the person-centered approach that all of you talked about here, and what matters and such. I want to stop for just a minute though and see if people in the audience have pressing questions, because we want to make sure we leave enough time for that. Some of you might be developing your own program. I think the microphone in the middle is where you need to speak, if you don't mind.
Hello. Hi, can you hear me? Yeah. Okay. So I guess I had a question. I'm a case manager in supportive housing with community access, and one of the things I wonder is that, like, I have a lot of people that maybe just turned 65, 66, 67, or a few, and like, I do all this effort to set up these doctor's appointments, but then they go, and I have no idea what these conversations are, and the cognitive ability of them to advocate for themselves just isn't happening. And I didn't even know, like, should we be connecting them to, like, geriatric care specialists? Are they in the wrong health homes? Is it, like, all? Because for what I'm seeing is, like, they're just kind of getting sidelined. And I don't have a relationship with physicians, and I can't call and talk to them to tell them this person fell 3 times this week. So I'm like printing out papers. I'm like, please hand this to your physician. You fell twice this past 2 weeks, right? So I wonder, like, how do we bridge that gap in services from, like, on the ground to, like, in the doctor's offices?
Great. Could everyone hear the question? Okay, great. Anyone like to take that?
Yeah, I could start. So the short answer to your question is yes, right? With your question about should I be sending this person to a geriatric specialist? Yes, you should. The problem is that I was looking for one for my mom. There's like one person in Brooklyn that would take her insurance, et cetera, like, right? And I'm sure she's booked up for months and months. So there's just not enough geriatric providers out there to deliver the kind of care that a person like that would really benefit from. And, Geriatric Care 101 gets at the thing you're there's a lot of things, but one of the things you're naming is this issue of information. Where does all the information go, right? Mm-hmm. Like, how does it get back to you? How does it get to does the patient even understand what's being told to them? To what extent is the provider being clear about what he or she is describing to the patient, right? So, the first thing a geriatric provider thinks about is like, okay, who knows what? How can I know it? And how do I get this information back out to whoever needs to know it? And how does this all get followed up on, right? And it sounds simple, but actually, well, it is simple. It's just that it really takes someone like a geriatric person or someone who's geriatric informed to, like, think that way. Now, we community people, to give us, to pat myself on the back, so when I started reading about that, I'm like, oh, I know, that makes sense to me. Why? Because I'm a community psychiatrist, right? So, here's one example, right? When I used to work at the hospital, I would just send a prescription and then forget about it. Like, I never knew what happened to it, and it never occurred to me to even ask. And my first day on this job, I realized, like, oh, wait a minute. This is back when we were using paper prescriptions. I just aged myself, right? How does that prescription get to the pharmacy? What pharmacy is it going to? How does where does the bottle go, right? How does right, like all this kind of, it's like the same kind of issue, right? And your average hospital person didn't even think about it, right? So I don't know if that's really answering your question. So I guess, and this is the last thing I'll say about this, I guess to answer your sort of basic question about this whole business of information transfer is, like, I could think you or some part of the system's got to set up a structure that makes that happen almost despite who the people in the structure are operating inside of it. Does that make sense? It, like, forces you to, so. Yeah.
So I'm finding roadblocks, because they won't fund because my dad has private insurance.
Yeah.
And that's why I'm like.
Actually, I'm gonna just because this is your previous question. I'll say one more thing about the funding thing. I think we're at an interesting. My people have a curse. May you live in interesting times. I think we're living in interesting times. I think two things are coming to a head. The one is the thing we're talking about is that the population is aging really quickly, not just people with lived experience of homelessness, just in general. And this country is like a little bit like see no evil, hear no evil, right? At the same time, all this like 1115 waiver activity is just like really getting started, right? And I don't have a crystal ball. I don't know what that's going to look like, right? But I wonder, I'll say it this way, I wonder if there's an opportunity in some of this 1115 waiver activity to like put this issue more in people's consciousness. Like, for example, Health and Hospitals is trying to set up, I guess they were doing an ACO, now they're doing an IPO or something else, right? But they're trying to like position themselves for this 1115 funding and resources. And and part of their process is they're like convening all these stakeholders in all kinds of different areas to try to figure out what they should set up to like address all these, right? And I'm actually part of a small group of people who's focusing more on palliative care, and we've been talking to them about, can we set up like a little bit of hospice operation inside one of the medical respites, right? The medical respite's already up and running, so can we fold it into that, right? So that's like an example of maybe there's an 1115 waiver opportunity inside of something they're already doing. That actually they started doing that, I believe, because anticipating the 1115 waiver, right? It's not the only reason they did that, but I think it's one of the reasons. So it'll be interesting to see how that all plays itself over the next 2 or 3 or 4 years. Oh, okay.
Does anyone have a good, coherent
I'm not the expert,
it allows
Leor, are you still
it allows and Leor, correct me if I'm wrong, but it allows basically the state to apply to the Center for Medicaid and Medicare Services to basically bend the rule a little bit in order to better serve the patients that they're meant to serve. That's the short answer of it.
And the state's submitting their application to the feds maybe this week.
Right now,
Like
yeah.
soon, yeah.
Yeah.
But can I answer the sort of like systems question that came up here? A couple things. So I think one thing that's happening sort of in social services, particularly this area in general, is that social workers and case managers and the medical field are sort of getting closer and closer together, right? Where medical providers are becoming using more and more sort of social working skills, and case managers and social workers are moving more and more into the like, oh, I have to be able to explain to this client what high blood pressure is or what's going to happen to them when they go in for this surgery, right? So that's one thing that's not necessarily here or there, but I just wanted to acknowledge it. And in terms of a solution to this, one of the things that we are in the process of doing at Breaking Ground is we have joined a health information exchange, a regional health information organization, that will allow us to get alerts, New York State, I think as a result of COVID, adjusted the consent laws so that if you are involved in the person's care, you can get an alert if they go to a hospital or an emergency room, even if the person has not given explicit consent. You won't find out why they're there, but you'll at least know that they walked in the door. And so we are just sort of moving our first pilot across the finish line of being able to start getting those alerts for some of our programs. And I've seen this happen in my previous work at BronxWorks, and it totally changed the way that we coordinated care, because we were able to then say, okay, I can't get the doctor to return my call, but I can go in and with this person's consent, I can actually look at the discharge note that the doctor wrote in the hospital so that I can read the medications they were prescribed and know that they didn't pick them up at the pharmacy.
I would also just add PACE programs, Google PACE. ArchCare PACE is in Manhattan and the Bronx, and they're a really specialized team that has helped a lot of our clients. Also, home health aides could be good historians, depending on the person, if they can get home care. Depending. At least they could hand the paper reliably sometimes.
Thank you all. And it sounds like there's an opportunity to potentially have a coalition or a group of people of like minds to think through some of these things together. I'm not.
Live On New York has convened a little bit of a like quarterly sort of roundtable around this, and was doing some work around budget time about getting some additional funding in this space. It didn't make it, but that a very small space does exist through Live On New York.
Great, thank you all. And we have someone waiting to ask a question very patiently. Thank you.
Hello, I have a question and a comment. Yes, I'm Mike Korn. I'm a member of SHOUT, which is a new organization that's trying to help tenants in supportive housing, make sure they have their rights and they don't get abused. Anyway, the question is, I just have, can you employ best practices between different supportive housing providers that engage seniors that would add to their quality of life? I mean, I hear that, Breaking Ground has one, way of doing things, and, the Bridge has another way, and you guys have another way, Cooks. And then how many other organizations, supporting housing providers have the same kind of, their own little program. But what's working best, right? Best meaning adding to the quality of life of the seniors that are in the programs, right? So is there a way of you guys collaborating, or, are you guys keeping your stuff to yourself? Are you have like a secret, or are you sharing that information? Because, if it's best practices, you should share that information and see that people, get the best information and help each other, rather than, oh, we're the Bridge, we're the Breaking Ground, we're, No. You might be different organizations, but you should at least do the right thing for your tenants and your seniors in your programs by getting best practices going and finding out what works the best. I don't know how many times I can say that, but that's half the comment. The comment is, it's really aging and thriving in place, right? So that kind of drew me, just that phrase, because my provider, ICL, tried to move me against my will from one place to another. During the COVID crisis, right, I was fine where I was at, my own place, right? I was very satisfied, had a nice west view, I could see the sunset, I loved it. And one day, my caseworker tells me, Michael, we love you, we tried to do our best for you, but there's nothing we can do, you have no choice, you have to move, right? And the program ended. The program didn't end, they lied to me, all right? So, how do you, I had to get a lawyer, and it worked out, I kept my place, but they wanted to move me out in the middle of the COVID crisis, to move in with a smoker, right? I have dyspnea, shortness of breath, among other comorbidities, so, do I need that? No. So that was one issue, and the guy planned to have friends come over. This is the middle of COVID, and they expect you to just like, oh yeah, that's blithely just say, oh sure, you said, oh the program's ended for individuals, and you have to move into a roommate situation. Also, the landlord was a slumlord on Tish James's 100 worst landlords in the city of New York. So, it's so many and there was also, I'm sorry, there was also a rent strike in the building. So, I mean, it's like, you know, I would have been a scab in a way, right? So, I mean, there's so many different things that were wrong, and they trying to move me anyway.
Is it Michael? Is that what you said you knew?
So anyway, that's, so finish, so I'm just saying that, I would like to age in thriving place, so please, let me do so, right? I guess that's my comment, but, you know.
I think we all agree. We would
Yeah,
love you to
absolutely.
do so. Yes.
Yeah.
I will say we have an article in the Journal of the Poor and Underserved, so we're definitely not trying to keep it a secret. You can, I can give you my card. I can email you the article, so you can read more about our program. So it's out there. Yes.
Great. I think best practices is always a great idea, and it sounds like it was a hard time. I'm sorry it was so hard, and thanks for raising those points. I wonder. It seems like a good moment to talk for a moment about the person-centeredness of your programs, because I think I was thinking about, as Rebecca was talking, how often, for example, you keep asking people, because people's whether they would like services, because people need to have choices. I think Michael just raised that for us, and may change their minds from time to time. So I wonder if you, even if you assess people when they're 55, do you keep coming back and asking, how are things going? You know, have you changed your mind about this or that? How do you handle that person-centeredness, or do you have a routine for it? Maybe Rebecca, would you mind?
Sure. Yeah, we definitely do our older adult needs assessment every year for everyone over 50, and. You know, of course, people can always be re-referred. So if, you know, we're a voluntary program, if they say, you know, I'm not interested anymore, and then things change, we always come back. And I do also think in terms of person-centeredness, often what happens with our older adults is that our own fear and our own idea of what limitations our clients have stop us from providing better care. So, you know, clients have a dignity of risk, right? We all have the ability to make choices that are sometimes maybe not the best choice, or not a choice that someone else would make. So I think my really vendetta against higher levels of care unless they're needed is that sometimes staff will say, oh, well, this person could fall or something could happen, you know, and I like to talk about Tom Cruise in Minority Report, right, where he's arrested for a crime, but he didn't commit it. You know, he was innocent. And so how can we put someone in a higher level of care, which is taking away their independence, right, taking away their dignity of choice and of risk because of our own fear around what could happen. So I think a lot of our program is really giving people, letting staff and maybe clients be more comfortable with risk, right, and be more comfortable with the reality and find ways to mitigate those risks and talk about it, but not sort of jump to this conclusion that because someone is an older adult, it means X, Y, Z. Of course, we know that's just not true.
Yeah, I think that we have also seen some re-referrals, and well, let me back up. So I think this was one of the lessons learned in our sort of Aging Services 1.0 under the grant funding. One of the outcomes that was sort of established for the initial seed grant funding was we're going to complete X assessments of all of these folks in our building, right? Which sets up an assessment as an end in and of itself rather than a means to an end. And so we realized that we needed to pivot. And so we developed a sort of like dual pipeline of referral, that we are no longer doing sort of cold outreach to folks who are already connected to the supportive services in the building. So if they are in a supportive unit, we sort of wait for the supportive housing team to come to Aging Services and say, hey, this person needs some additional help. For folks who are in the community units, we take a more proactive approach to outreach them, and then maybe ask them a very sort of brief survey of how they're doing. If they tell us to take a hike, we take a hike, and then come back and say, okay, we're here if you need us, right? And then we aren't doing things annually. We haven't really hit our stride in terms of figuring out what the sweet spot is of going back to folks after a certain amount of time. But as we sort of continue to settle in, we've only been around for about 3 years. As we continue to settle in and word spreads about the services, we're hoping that some of the folks who initially, whether because their needs changed or because they just weren't interested the first time, who sort of passed on the services previously, will be willing and sort of seek out our services in the future.
I really like what you're saying about risk, and I think, Rebecca, you raised it. And I also remember when you began, you started to talk about the more or less the buy-in from your organizations, and that it has to permeate, I assume. I wonder if you have any advice for people in the room on, people could be at all different points or in different positions at their organization. They obviously care about this issue because they're here today. Do you have any advice as they navigate this to handle that risk? And there's something nice about it being in this nascent stage, and that there isn't a mandate that everybody who is whatever, 60 or whatever, has to do X, Y, or Z. What you're talking about is still person-centered, and not that it wouldn't be if it got regulated a little more. But I wonder about that, and I imagine people could use some advice as they navigate.
I mean, I think some things that people could start doing tomorrow, right, is maybe you don't have an older adult needs assessment, but there are a lot of assessments out there, big and small, right, as Van was saying, that you could start asking your clients. Home care agencies love when you call them. You could call them. They come. I had to tell them to stop bringing us donuts. I was just like, this feels inappropriate. They were always there with donuts, because they're for-profit, obviously. But, to make some connections with home care agencies, with PACE programs, start to have your own little Rolodex of places. Start talking to clients about advanced directives. A lot of these things you can do in a small way. Obviously, it's great if you have a bigger initiative or a bigger program, but there are kind of small connections and trainings, and I'm glad to give out my card and give more advice if people have ideas or want ideas about partnerships and connections to start to build with your agency to benefit your clients.
Thank you. Are there any other questions, or would either of you like to comment on that same question?
I don't have anything in particular.
Okay. Any other questions from audience members? Okay.
So I was wondering what systems you had in place, for successfully graduating from supportive housing as a senior, right?
Did everyone hear the question in the back? Okay.
So
Okay.
yeah, if you're successful systems for successfully graduating, buy-in from them, but also if cognitively, they cannot understand their options or understand what's going on. Where do you draw that line? And what have you done successfully? Or what policies you've changed to implement at that level? Because I know we have that biopsychosocial when they join, and then that's kind of it. That sits there, and that's just at that point in time. So where do you kind of graduate from after that?
I'll take although I'm not sure I'm understanding the question. So,
What does successfully mean?
So, I mean, to assisted living or
Got it. Okay.
Oh.
to nursing home. Because, like we said, someone might seem like they're 20 years or older than they are, right?
Right.
So when does that? Because it's not necessarily that people are going to being hospitalized, but
So are you saying normalizing that transition?
normalizing that
Okay.
transition or instituting policies around that transition.
And I think it's really case by case. I mean, at least at the Bridge, I guess the benefit of having a specialized team is it's more standardized. I think nobody goes to a nursing home unless my team is involved. So we can help say, have you tried this? Have you tried that? Or we meet with them and we say, yep, we really think that this is now the appropriate next step. I think successful aging looks different, right? I mean, we had a client recently who died in his apartment, and I think that was a really successful death. That was a really great, that's what he would have wanted. So, I would be wary about having a policy, because I mean, the kind of all the things I said before, right, about why it's so important that it's person by person. But I think if the agency as a whole is really focused on ensuring that it's only happening when it's appropriate and we're not institutionalizing someone in a nursing home because of our own discomfort of liability, then I think it is successful depending on what the person needs.
And I think it also comes back to the sort of idea of engagement, right? And sort of having conversations with folks. This doesn't mean, obviously, to your point that you made earlier, supportive housing was not necessarily set up to sort of catch all of these folks for this length of time, right? It's great that it has, but it's a sort of unintended situation in which we find ourselves, right? And so I think part of the normalization is also just helping people understand that this is a normal part of the aging process. We're all aging, right? How would that conversation look with a parent or a caretaker if they weren't in supportive housing, right? And making it so that it's not just like, oh, we've taken your apartment away from you, right? But engaging the person in a conversation about why it might be beneficial to them, and that may require some modification depending on their sort of cognitive understanding. But to your point, sort of not writing the person off as, okay, this person needs a higher level of care, and because they're in supportive housing, we're going to sort of like say that's the route and we'll see you later, right? Sort of engaging the person in the conversation as you would anyone who was living in the community. And I think that ultimately that is because this doesn't only happen in supportive housing, right? The idea of going to a nursing home or sort of giving up your independence, it has special sort of nuances for our folks, but that's a scary conversation and a scary sort of thing to admit to yourself in general, and may take on additional significance if, like, this is the person's been in their unit for a year, it's the first time they've lived by themselves in 35 years, and now all of a sudden they're facing going back into a more congregate setting, right? But doing some work around sort of like acceptance and normalizing the process of transitioning, I think is key to that.
Great. I think, John, you brought us back nicely to the way we opened, which was that this is a process. It's a good problem, I guess, to grapple with in some ways. And there's a lot of work to do. So I really, really thank you, all three of these panelists, for sharing so much of what you're doing and the varying stages, and for all of you for your great questions and attention. And thank you so much.
Thank you, Tracy.